Yeah, I think there's an overarching message from all of us that every lab has their own way of doing things. There's no one-off recipe, and I think that's one of the fun things that I find when I go out and do CAP inspections or when I offsite a lab and I see how my solutions don't work in every lab, and every lab has to find their own little ways of coping and know their own data. So I'm going to talk about embryo selection and considerations that all labs, I think, kind of go through are thinking about minimizing your embryo exposure. So how many times do you take the embryos or the eggs in and out of the incubator? Are you using media that we were just hearing about, single step media or sequential media? And there are more labs using time-lapse now. So is time-lapse a consideration for your lab? Or are you doing cleavage observations? Are you using those cleavage observations on day 2, day 3, day 4? Are you really using the data that you're collecting? And one of the things that I notice when I go out to a lot of different labs is they're busy writing all the data down, but they don't necessarily utilize that data to make clinical decisions. So I think it's all something to think about and be introspective about. Is your lab doing assisted hatching? If so, what day? The number of embryos that you have available, does that determine whether you would consider doing a day 3 or a day 5 transfer? Some labs think a lot about uterine synchrony, and there are certainly more and more labs in the US that are turning into cryo-all, where they virtually cryo every cycle, freeze all their embryos, and then bring the patient back for an FET cycle later. And I think it is important to know your own data. That being said, hopefully my slides are going to advance here.
You have to use the thing on the bottom left, Dawn.
The bottom left.
Of the PPT, there'll be an arrow that should come up.
It's not giving it to me. Hang on one second. We strive to use minimal exposure, but also to balance the data that we want to get that we think is relevant data. So at Yale, we're using a single step media. We use global total media. We do not use time lapse, but we do a snapshot view, which is a day 2 observation, which is one of the primary algorithms that are used for time lapse. And what we do with that snapshot algorithm is that that snapshot view, we sort our embryos on day 2 into like groups. So we'll sort into a 5-well dish. We'll sort our embryos that are 2 and 3 cells into one well, 4 cells into another, and greater than 4 cells. And what we historically looked at was when we biopsy the blastocysts that come from those embryos, the blastocysts that come from 4 cells or greater than 4 cells are much more likely to be euploid. So if we're not doing PGT, then that embryo selection can help us select the embryo that's the most likely to be euploid. So that was a very important observation for us. And so because we wanted that day 2 observation, we moved our assisted hatching to be done on day 2 so that we didn't have to expose the embryo twice. So day 2 hatching, we do a select number of patients with a day 3 transfer. So if it's an older patient that only has 1 or 2 embryos that's not doing testing, then we may very well defer to a day 3 transfer. Right now at Yale, across all ages, we have a lot of poor responders. Across all ages, we're at about 30% day 3 embryo transfers. We also do select cryo-all depending on a few factors. We do select cryo-all when the progesterone is elevated on the day of trigger. So for us, using a Roche E411, that means a progesterone of 1.2 nanograms per mil. And that's where our pregnancy rates start to drop. The Roche is particularly sensitive in that range, but some other assays aren't. So again, you have to know your specifics of your particular lab. We also at Yale would turn into a cryo-all if we had a very early blastocyst like the one shown at the bottom right. So what we want to see on the morning of day 5 is a 2 BB or better. So if we've got early blastocysts in a fresh cycle where it's a stimulated uterus, we'll turn those into to freeze-alls. We'll culture them out to day 6 and cryo-all at that point. That being said, this particular embryo was from an egg bank thaw. It was transferred on day 5, and that's because in that egg bank thaw, we're actually working with a frozen uterus, so with a hormone replacement, so we could match the synchrony better that way. So all considerations that we have. For those of us that are considering embryos for day 5 or day 6 biopsy, we have considerations for whether you zone a breach on day 2, 3, 4, or with biopsy. There's lots of labs out there that are just breaching when they go and do the biopsy, and about as many different opinions. Do you consider your lab schedule? Of course, you have to have the embryologist's time available to biopsy when the embryos are available, and you have to work practically within the rest of your confines. Considerations of embryo expansion, how cellular the embryo is, position of the inner cell mass, the best time to VIT, whether it's immediately or whether you allow the embryo to re-expand, whether some places recollapse the embryo even after it expands after they biopsy it, and knowing what your best survival is, and again, knowing your own data. So at Yale, we breach on day 2. The majority of our embryos are biopsied on day 5, late on day 5. Greater than 60% of our biopsies are performed on day 5. The rest are performed on day 6, with very rarely embryos being biopsied on day 7 if they're progressing nicely and they're just slow. And occasionally we do get a euploid embryo from those day 7 embryos, but again, it's very rare. So for our hands, what we would generally use is about greater than or equal to 5 cells hatched out. So if we're looking across the band of embryos at the top, obviously we wouldn't be biopsying the first embryo or the second one. The third embryo is where would be the earliest limit that we would consider biopsying. And obviously we like to see more advanced stages. And the majority of our embryos look more like the 4th embryo when we biopsy. So for us, there's little consideration of where the inner cell mass is. We tend to just work around it, unless it's just really in the wrong spot on day 5, and we might let it go to day 6. Obviously, for us, what we do is we biopsy all the embryos. We VIT after tubing, so that takes about 30 to 60 minutes. So we allow for partial re-expansion, but not full expansion. And this is just a fun slide that I thought I would pull up again from years ago, and that is which of these embryos made a baby. And when we try and pick, it's frequently not very apparent. And the truth of the matter is, with all of these embryos, every single one of those embryos resulted in a baby being born. So my favorite's the bottom one, where there was a singleton girl. That's my most favorite ugly embryo. Anyway, so I'll pass it back. I'm going to pass it on now to Maria Jose de los Santos. She's the director of the clinical embryology at IVI Valencia and designated participant from Spanish government for the 3rd and 4th edition of the Guide to the Quality and Safety of